Welcome to online anesthesia video of the week. Today topic is presented by Dr. Venkateswaran, working as senior consultant anesthesiologist Ganga Hospital, Coimbatore. His major achievements are as CTLS instructor for the past 12 years, faculty for FNB trauma anesthesia and critical care in NBE. Participated as faculty for national and international conferences. 6 paper publications in international journals. Postgraduate teacher for DNB and FNB programs in Ganga Hospital. His areas of interest are resuscitation of major polytrauma and perioperative care, regional anesthesia in acute trauma, pediatric regional anesthesia.
Hello everyone, I am Dr. G. Venkateswaran, Senior Consultant Anesthesiologist from Ganga Hospital. I am going to talk about lumbosacral plexus block by peripheral nerve stimulator. First of all, I have no conflict of interest regarding my presentation. We usually get a photographic consent from the patient, and that is the consent form. Because this presentation has got a lot of videos being taken from the patient, so we used to get a consent for using that in many of our presentations. I would like to start with a small case scenario. A 55-year-old male with a gangrene of left leg came with the blood sugars of 540 with a HbA1c of 11%, was having an elevated urea and creatinine present, and is also having an ischemic heart disease with an ejection fraction of 30% with severe LV dysfunction. The plan is to do a left elbow knee amputation as an emergency procedure. So we controlled his blood sugar with IV insulin infusion. Then we took him for surgery of left elbow knee amputation under lumbosacral plexus block. So this is the gangrene leg, and this is the amputation which has been done, and this is the amputation stump which is later closed. Why lumbosacral plexus block for these type of surgical procedures? Because the lumbosacral plexus block produces a complete anesthesia to the lower limb. There is no hemodynamic disturbances even when the ejection fraction is low. A tourniquet can be applied and surgery can be done without any blood loss. Even patient with mild sepsis, it's not a problem. This block can be given. It also gives a very good post-operative pain relief for more than 8 hours. So, these are the pictures of the patients who has got severe diabetic foot with necrotizing fasciitis presenting with a lot of autonomic neuropathy. When you take them for surgery under neuraxial block in the form of spinal or epidural, these patients will end up in an exaggerated hypotension because of the severe autonomic neuropathy which is persisting. And also they also have under neuraxial block, they develop urinary retention. And long-standing diabetic patients has got high chances of developing epidural abscesses when you give a neuraxial block. And the hypotension which is present following the central neuraxial block can even lead to early thrombosis of the ischemic leg. So that's the reason why we do a lumbosacral plexus block in these type of patients. So coming to history of the lumbosacral plexus block, it was started in the year 1974 by Winnie, and which was done by a landmark technique. In 1989, Parkinson's did lumbar plexus block with peripheral nerve stimulation. And it was in the year 2001, Kirchmeier did an ultrasound-guided lumbar plexus block. Coming to the anatomy of the lumbar plexus. Lumbar plexus is formed from L1, L2, L3, and L4, and also a small tick from the T12 joints to form the lumbar plexus. This plexus is formed within the muscle of the psoas major. So this is the psoas major, and all the branches of the nerves of the plexus will come out of the psoas major. The main branches are iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous nerve of thigh, femoral nerve, and the obturator nerve. And this is the cadaveric picture. Following the dissection of the psoas major, we can see the presence of lumbar plexus within the substance of the psoas major muscle itself. And this is the CT contrast, which is done after a lumbar plexus block with a contrast. And the CT taken shows the whole psoas major muscle gets soaked with contrast. So that means the whole lumbar plexus is formed within the psoas major muscle. Once the lumbar plexus is formed within the muscle, the branches arise. The main branches may be the ilioinguinal, iliohypogastric, lateral femoral cutaneous nerve of thigh, and the femoral nerve. They come out of the lateral border of the psoas major muscle. Then this genitofemoral nerve comes over the anterior border of the psoas major muscle, and the obturator nerve comes mainly over the medial border of the psoas major muscle. So that's how the branches arise on the either side of the psoas major muscle. And coming to the sacral plexus, the sacral plexus is formed from lumbosacral trunk, which is formed from L4 and L5. This lumbosacral trunk joins with S1, S2, S3, and S4 to form the sacral plexus. The main branches of the sacral plexus are superior gluteal nerve, inferior gluteal nerve, sciatic nerve, posterior cutaneous nerve of thigh, and pudendal. And the sacral plexus are formed beneath the muscle of the piriformis muscle. And we can see all these branches arise on the either side. That is, the superior gluteal nerve runs over the superior border of the piriformis muscle, and all other branches will run below the inferior border of the piriformis muscle. Coming to dermatome, myotome, and osteotome of the lumbosacral plexus, especially the lumbar plexus, the femoral nerve component supplies the anterior and medial aspect of the thigh, and the saphenous branch of the femoral nerve supplies the medial aspect of the leg. The lateral femoral cutaneous nerve supplies the lateral aspect of the thigh, and the sacral plexus, you can see it supplies the dermatome, it supplies the posterior aspect of the thigh, and also the leg portion, as well as the lateral and anterior aspect of the leg is supplied by the sacral plexus. Coming to the myotome, the quadriceps area is supplied by the lumbar plexus, and the hamstring part is supplied by the sacral plexus, and the whole part of the leg is supplied by the sciatic nerve. Coming to the osteotome, you can see the hip joint and knee joint is supplied by the lumbar plexus and also by the sciatic nerve, and the ankle joint is mainly supplied by the common femoral and the tibial part of the sciatic nerve. So this is about the dermatome, myotome, and osteotome of the lumbar and sacral plexus. So the indications of lumbosacral plexus block, and you can see this lumbar and sacral plexus block, it forms the sole anesthetic for the entire lower limb surgeries. It is used for the perioperative management of total hip replacement, total knee replacement, and all knee surgeries. Above and below knee amputation in multiple comorbid illnesses with low ejection fraction and severe LV dysfunction and sepsis, we can use this lumbar sacral plexus block. Patients having a severe diabetic autonomic neuropathy and lower limb surgeries can be done under this plexus block. And sacral plexus block can be used for relieving the cancer pain in the perineal region, especially the CS cervix, and also sacral plexus block will help in relieving the cancer pain. The contraindications for the lumbosacral plexus block is absolute contraindications are patient refusal, local anesthetic allergy, local skin infection, and coagulopathy. The relative contraindications are sepsis, prior retroperitoneal surgeries, and progressive indeterminate neuropathy. How will you identify the lumbar plexus? So lumbar plexus is identified by three techniques. One is by loss of resistance, which has not been done nowadays, which has been done in the past. And nowadays we do it under peripheral nerve stimulation. And the third mode of identification is using dual mode, using both ultrasound and peripheral nerve stimulator. In this talk, I'm going to present only about the lumbar and sacral plexus block by peripheral nerve stimulation guidance. First, we'll go into the lumbar plexus block by PNS guidance. So the general considerations are, first you should get a consent, an IV access, and the standard monitoring like pulse oximeter, ECG, and non-invasive blood pressure is needed. These patients should always undergo a light sedation with injection fentanyl and midazolam, and it should be an absolutely sterile technique like how we do for neuraxial block. So the equipments needed are, it is a sterile marker scale, sterile marker pen, 2 ml syringe with 2% lignocaine, 20 ml syringe with a 10 centimeter stimiplex needle, and a sterile cup with a local anesthetic. We always take about 20 ml of 0.5% bupivacaine, and 15 ml of lignocaine with adrenaline, and 15 ml of saline is usually taken. So it has to be mixed as a mixture, and it is taken inside a sterile cup. So we use 25 ml for lumbar plexus and 25 ml for the sacral plexus. So that's why the total component of 50 ml will be used. And of course, we need a peripheral nerve stimulator for giving this block. So the position of the patient will be, it will be a lateral position with a slight forward tilt. And after positioning, should always give IV sedation with fentanyl and midazolam, hold in oxygen. Hudson mask should also be applied. So this is a short video of the lumbar plexus block. You can see the patient is connected to the monitors. Patient is connected to the monitors, and the back is painted with chlorhexidine solution. The entire back should be painted, and back as well as the gluteal region is painted. And then the nerve stimulator needle is flushed with local anesthetic. Sterile marker pen and scale is also present. And now we have to start marking the posterior superior iliac spine, which looks like a small dimple in the back, which can be identified. And the second landmark is we have to find out the upper border of the iliac crest. With your hypothenar eminence of the hand, we can feel as a bony hit when it comes down. And then from the upper border of the iliac crest, you have to draw a line which connects to the upper border of the iliac crest on the opposite side. So this line is called as the intercrystal line or Tepheus line. And the third one will be the mid-spine. At the level of spinous process, you draw a line, it's called mid-spinal line. So from PSIS, you draw a line perpendicularly up where it meets the Tepheus line. So this is the one which is very, very important. And you can see the meeting point will be usually 4 centimeters from the midline. This 4 centimeters corresponds to the length of the transverse process. So where the most important thing is about the line from the PSIS where it meets the Tepheus line. So this is the point of insertion for lumbar plexus by Vinnie's technique. So give adequate amount of local infiltration with lignocaine with adrenaline, both skin and subcutaneous tissue. Then you take the 10 centimeter stimiplex needle, introduce into that point, and then it should be perpendicular to the table. It should be parallel to the table and perpendicular to the skin. And you start stimulating with 1.5 milliamps current. So by about 4 to 5 centimeters, you can see the needle will come in contact with the transverse process. You can see this needle is in contact with the transverse process, where beyond you can't go. Once you hit the transverse process, you go either cephaloid or caudal. And once you go cephaloid or caudal, keep in mind we should not cross more than 1.5 to 2 centimeters from the osseous contact of transverse process. So by continuous stimulation, you'll be able to get a quadriceps twitch by 1.5 to 2 centimeters. You can see this quadriceps twitch, which appears, it indicates the needle is very close to the lumbar plexus. You start reducing the current from 1.5 milliamps, you start reducing, and you can see it is there up to 0.5 milliamps. The quadriceps twitch is present, and it is the point we can say this is the end motor response for the lumbar plexus. You start aspirating and injecting the drug. And while you inject every 2 to 3 ml, you aspirate and inject the drug because this plexus is very vascular. You have to avoid injecting any intravascular injection has to be avoided. So total 20 to 25 ml of local anesthetic is given for a good lumbar plexus. So this is what we have seen by Vinnie's approach, where you can see this line drawn from PSIS where it meets the Tepheus line. So this point is for meeting is for approach by Vinnie's technique. If you go 1 centimeter medial to this point and insert the needle, that is called as Capdeviel's technique. So the C is for Capdeviel's technique, which is be 1 centimeter medial to the Vinnie's. Both the techniques we can do, but I always prefer this Vinnie's technique. So the goal is, so once you reach the transverse process, the distance from the transverse process to the lumbar plexus should not be more than, you should not go beyond 1.5 to 2 centimeters. It is fixed. So lumbar plexus is situated in front of the transverse process by about 1.5 to 2 centimeters. It is same for a thin individual, it is same for an obese individual, and even for different races, it's going to be the same thing. And they always start with 1.5 milliamp current with zero 0.1 millisecond duration and 2 hertz of frequency in a peripheral node stimulator. Always look for visible or palpable twitches of the quadriceps muscle at 0.3 to 0.5 milliamps. Sometimes in severe diabetic patients, you won't get by 0.5. You will be able to get by 0.8 to 1 milliamps. Even that is also acceptable. If you get a good quadriceps twitch, that's how we have to proceed the block. The possible depth of the lumbar plexus is about 6 to 8 centimeters. The volume usually leads is 20 to 25 ml. In pediatrics, it is 0.7 ml per kg for pediatrics. How will you assess the block? So onset time, it usually takes 15 to 20 minutes for the block to get complete. The first sign of onset of a block is loss of sensation over the saphenous nerve region. That is the medial aspect of the ankle. If you pinch and see there is no pain, then it means it's the first sign of onset of lumbar plexus block. And there is a pain relief on rotational movement of the leg. The patient is unable to extend the blocked leg, and we can, with a quadriceps weakness, that means the block has taken well. What are the pitfalls and corrections while giving PNS guided lumbar plexus block? After walking over the transverse process, if there is no quadriceps contraction, that means the needle has to be deviated either 5 to 10 degrees medial, lateral, cephaloid, or caudal until you get a good quadriceps contraction. So that's how we have to do. Suppose instead of quadriceps, if you get a hamstring getting stimulated, then it means the needle is close to the sacral plexus. So in such case, that means the needle is medial or it is caudal. It means there is a high risk of entering into the epidural spread. So what you have to do is immediately you have to withdraw the needle. If you get a hamstring stimulation, you withdraw the needle and go laterally until you get a quadriceps twitch. Sometimes you can get both quadriceps as well as hamstring twitch. That means your needle is close to the lumbosacral trunk. So in such case, you withdraw the needle and redirect the needle laterally. Sometimes you can even get flexion of the thigh. That means the psoas major muscle is getting stimulated. So don't give any injection there. You just withdraw the needle and redirect it laterally so that you get a good quadriceps contraction. In some situations, you can get contractions of the, that is abdominal twitch may be there. That means the nerve is stimulating the iliohypogastric nerve. You just withdraw the needle and redirect it until you get a quadriceps twitch. So the end motor response is always a quadriceps twitch. Don't go for any other twitch for lumbar plexus block. And now we'll come to the sacral plexus block. So when you see of the sacral plexus block, it is this. So it is first landmark for that what you have to identify will be the ischial tuberosity. So you have to identify the ischial tuberosity. You can feel from the upper lower aspect of the thigh, you come up, the first bony hit, what you get is the ischial tuberosity. So that is marked. Then you draw a line from the PSIS, what you have marked for lumbar plexus. From there, you join PSIS to the ischial tuberosity. So once you join this, we can see the same line continues up to the lumbar plexus. So we can see this. So if you draw this line and you select upper 1/3 and lower 2/3 of the line joining from PSIS to ischial tuberosity. So on this junction where upper 1/3 and lower 2/3 is the point of insertion for sacral plexus, give adequate local and then introduce the 10 centimeter stimiplex needle. Once you introduce, you can start, you'll be able to see a gluteal twitch. That means you are in proper direction. You start reducing the current from 1.5 milliamps, and then finally you'll be able to get a hamstring twitch, a gastrosoleus twitch, and finally you'll be getting a plantar flexion. So either plantar flexion or dorsiflexion is an end motor response for sacral plexus. You reduce the current from 0.5, you can start reducing it. And if you get a good plantar flexion or a dorsiflexion at 0.5 milliamps, then it means it's an end motor response for sacral plexus. And this is how to identify the sacral plexus. Then once you see this, then you start aspirating and injecting. So here also every 2 to 3 ml you aspirate and inject the drug. It's very, very important because these two plexus are very highly vascular. So here we give around 25 ml of local anesthetic mixture what you have taken. So this is how we have to give a sacral plexus block. Remember, every 2 to 3 ml you aspirate. The depth will be about 6 to 8 centimeters for reaching the sacral plexus. So this is how you'll be able to do the sacral plexus. So the goal for the sacral plexus is once you go at this point where upper 1/3 and lower 2/3, you'll be able to needle by 4 to 5 centimeters, you'll be able to hit an osseous contact that is nothing but the sacral wing. And once you hit the sacral wing, then you redirect the needle caudally or laterally, but don't go beyond 2 centimeters for a sacral plexus. So don't go beyond 2 centimeters from the osseous contact of the sacral wing for sacral plexus. The end motor response is either dorsiflexion or plantar flexion, which you'll be able to get between 0.3 to 0.5 in normal individuals. In diabetic patients with an autonomic neuropathy, you can get by 0.8 to 1 milliamps. That is also acceptable. The depth is 6 to 8 centimeters for sacral plexus. How will you assess the block for a sacral plexus? So you just pinch on the posterior aspect of the thigh. If there is no pain, then the sacral plexus has taken. You can keep your hand below at the plantar aspect of the foot. Ask him to push your hand. If he's not able to do, then the tibial nerve gets blocked. And if you try to keep the hand over the dorsum of the foot, ask him to lift the hand. If he's not able to do, then we can say that common peroneal nerve is blocked. So this is how to assess for sacral plexus block. So after a block, you can ask the patient to lift the leg, opposite leg. You'll be able to lift, whereas the blocked leg, you won't be able to lift. And then you can check with the painful stimulus over the lateral aspect of the thigh for lateral femoral cutaneous nerve, or the medial aspect of the thigh for the femoral nerve, and posterior aspect of the thigh for posterior cutaneous nerve of thigh. So this is how we can check all these things. Always important that you have to check, and once it gets a good motor and sensory block, then only you should ask them surgeons to proceed. Suppose if he is not able to lift the opposite leg, if he is not able to lift the opposite leg, then we can think the drug has gone into the epidural space also. If he is able to lift the opposite leg, then it means a good lumbosacral plexus block. If he is not able to lift the opposite leg, and if you see some hypotension which is happening, then you can imagine the drug has gone to the epidural space. So that's how we have to detect whether the movement of the drug. So as you see this, this is the place where we give a lumbar plexus block by Winnie's technique, and this is from the PSIS to ischemic tuberosity, where we draw a line and we divide it to upper 1/3 and lower 2/3 for sacral plexus. You can see this entire line is almost a straight line coming from ischemic tuberosity up to the point where we give a lumbar plexus. This line is almost, it will be straight. So these are all the landmarks that you should always remember. Remember, it's very important for a PNS guided, the landmarks is very important, the marking is very important, and all these things is makes a good lumbosacral plexus block. Now, suppose there are certain challenges, like this patient has undergone a below knee amputation. Now he comes for refashioning of the below knee stump. Because of the comorbid illness, we are planning for a lumbar and sacral plexus block. So we can give a lumbar plexus block because the knee is there and the thigh is there. We'll be able to see the quadriceps twitch and give a good PNS guided lumbar plexus block. But what about sacral plexus block? Because he doesn't have a foot, then how will you look for a plantar flexion or dorsiflexion of the foot? So in such case, for identifying the sacral plexus, what you can see is the end point of sacral plexus will be a gastrosoleus twitch or a hamstring twitch. If you get between 0.3 to 0.5 milliamps, that is an end motor response for sacral plexus block. So in this amputation, the sacral plexus block, you look for the end motor response in the proximal part of the leg, that is gastrosoleus muscle twitch or a hamstring twitch. Suppose if the patient has got a below knee amputation then. So this is a short video regarding the patient having a below knee amputation done, and we are planning for a lumbar plexus is already given, like looking for a quadriceps twitch. But while getting the sacral plexus block, we can see that the twitch will be, we can see that the twitch will be able to see a hamstring as well as a gastrosoleus twitch. If you get the hamstring or a gastrosoleus twitch, then it indicates the needle is close to the sacral plexus block. Then you can start injecting the drug, especially in case of below knee amputations. Next is, suppose if the patient has got an ebony amputation and they want to do debridement of the ebony stump. So for a lumbar plexus block for ebony amputation stump, we can also do with PNS guidance. So what you can do is, when you give this, you'll be able to get a quadriceps twitch, because the thigh, anterior part of thigh is there. You'll be able to get a quadriceps twitch and start injecting for lumbar plexus. And for sacral plexus, and this is a short video regarding the sacral plexus. So what you can do is, so here also we can see the same point. You'll be able to see a hamstring twitch. And when you start introducing the needle, you'll be getting a hamstring twitch. And then by about 0.3 to 0.5 milliamps, if you're able to get a hamstring twitch, this is how we can give a sacral plexus block for a patient who has already undergone a ebony amputation. So these are all the challenges when there is no foot or the leg. How will you look for the end motor response? Always go slightly proximal to your end motor response in these type of challenging situations for a good lumbar and sacral plexus block. About perineural catheters, a continuous lumbar plexus block can be done with the Vinny's technique, with the same way that I have told for PNS guidance. And using a continuous catheter minimizes the need for opioids in case of hip, femur, and knee surgeries. Whenever you do a continuous lumbar plexus block, the needle hub or the needle opening should be facing cephaloid. So this will facilitate the catheter placement. The catheters are inserted not more than 5 centimeters beyond the tip of the needle. The continuous infusion always requires an intermittent boluses, mainly for the success. Suppose if there is a breakthrough pain is there, you always need an intermittent boluses in case of lumbar plexus continuous catheters. So this is very useful as a limb-specific anesthesia, which allows early ambulation and effective physiotherapy for lower limb procedures. Coming to the complications of lumbar and sacral plexus block, the complications are from the needle puncture itself. Complications from needle puncture, there can be a direct trauma to the nerves, which we can avoid by using short bevel needle. There is a chance of intraneural injection when you use the PNS less than 0.2 milliamps. There may be a damage to the abdominal viscera. Commonly, renal capsular hematoma can happen in case of lumbar plexus block by PNS guidance if you go above L3 level. Because this lumbar plexus is highly vascular. If one of the lumbar vessels gets punctured, it produces what is called retroperitoneal hematoma or a concealed hemorrhage. So this concealed hemorrhage can produce a hypovolemic shock following a lumbar plexus block. You have to be very careful when you are giving, always aspirate and inject, and this chances of retroperitoneal hematoma can be very grave also. When you use catheters, there is a chance for psoas abscess, because all these are long-standing diabetic patients. And psoas major hematoma, which has been produced, can also produce what is called lumbar plexopathy. So you have to be careful. Another complication is complications from incorrect local anesthetic placements. Sometimes there is a chance of epidural spread. The incidence is 3 to 27%, which can produce a hemodynamic instability. Some very rare cases, there is also a spinal spread, which can produce a total spinal anesthesia. Another thing is complications from local anesthetic itself, which can produce called local anesthetic systemic toxicity. In case of sacral plexus, there may be an injury to the small bowel, rectum, vaginal vault, or iliac vessels in case of sacral plexus block. So here also you should try to avoid further movement of the needle. So these are all the complications regarding lumbar and sacral plexus block. How to avoid complications by PNS guidance? So it's very important. Osseous contact will help to avoid complications. So osseous contact of transverse process in lumbar plexus is very important. So once you hit the transverse process, don't insert the needle 1.5 to 2 centimeters beyond the transverse process to avoid any complications, because all the lumbar plexus are present within this distance. So don't go beyond it to avoid complications. Avoid medial angulation of the needle in case of lumbar plexus block. Avoid high pressure injections. It's always beneficial that if you always use an ultrasound to detect the needle tip and look for the spreading of the drug whenever you give a nerve stimulator guidance. Also use ultrasound to detect the needle tip. That is also will be very useful. So to conclude, so lumbosacral plexus block forms a sole anesthetic for entire lower limb surgeries. It can be safely used in patients with multiple comorbid illness coming for lower limb surgeries. In lumbar plexus block, avoid needling 1.5 to 2 centimeters beyond the transverse process osseous contact. In case of sacral plexus block, avoid needling 2 centimeters beyond hitting the sacral wing osseous contact. Perineural catheters by lumbar plexus are very useful. It helps in early ambulation and helps in an effective physiotherapy. Thank you so much for your patient listening.